All right, welcome back everyone. So my name is Cecilia Hislop, and I'm going to talk to you now about what you need to consider when thinking about blood pressure, cardiac output, oxygen delivery, and oxygen consumption. I have nothing to disclose, and the objectives of this session are to describe blood pressure, cardiac output, oxygen delivery, and oxygen consumption, to recognize changes in cardiac output and oxygen delivery, and to evaluate trends in partner and lab markers such as lactates and mixed venuses, for example. To use the history, the operative events, recent echocardiograms, and other imaging to consider the most likely causes of a drop in cardiac output or a change in cardiac output or oxygen delivery. To synthesize all of this information and prioritize which causes of low cardiac output states need immediate treatment. Manage impaired cardiac output and oxygen delivery based on our understanding of the likely causes, and then frequently reassess and reevaluate our patients to see whether or not our plan is as expected. So if you were to look at these two patients, what assessments will you make about cardiac output, oxygen delivery, and oxygen consumption? Which of these patients would you be most concerned about? And I'm pretty sure probably most of you would say the patient on the right who has an open sternum, who is actually sternum is suspended. This patient is multiply invaded with lines and catheters and intracardiac lines and pacing wires, art lines, CVs. He's intubated and ventilated, and he has a NIRS monitor on his forehead as well, and probably on a whole lot of drugs. Whereas the other little patient on the left here, he looks like he's pretty much getting ready to go home. He's still got his pacing wires on, he's extubated, he's on a little bit of oxygen by nasal prongs, he probably has still his art line or peripheral IV in, and he's still got his pacing wires, as we said. However, we should never let our guard down, because the little patient on the left may be at risk of some of the things on the patient on the right. And some of those things are infection, cardiac arrhythmias, seizures, strokes. There are many renal failure, respiratory failure. So there are many things that this patient may suffer from, even though this patient is, looking like he's getting ready to go home at least. So the patient A is a patient with a VSD. And what do I need to think about then when thinking about blood pressure, cardiac output, oxygen delivery, and oxygen consumption for this patient? So what are all the possible threats to his cardiac output and oxygen delivery? And so we've identified some of those. The patient B is truncus. So what are the things that we need to think about him? For instance, he might have pulmonary hypertension, which may be a real risk for him. So again, we need to think about his blood pressure, his cardiac output, his oxygen delivery, and his oxygen consumption. And this patient is a very different story. So we need to think about all of the possible threats to his cardiac output. We also need to remember that a truncus isn't a truncus isn't a truncus, and a TET isn't a TET isn't a TET, that you can have some patients that do very well and some patients that are fraught with difficulties and potentially have a cardiac arrest. So when we're looking at cardiovascular monitoring, well, oxygen delivery depends on cardiac output, which is dependent upon a good heart rate. So a heart rate that's not too slow, not too fast, not irregular, not having arrhythmias, and stroke volume. So the stroke volume is the amount of blood that is beating with each heartbeat. So how much blood is ejected with each heartbeat from the right and the left ventricle. And stroke volume, the amount that's ejected with each beat, is dependent on preload. So how full is the heart? Afterload, what are they trying to pump against? So are there outflow tract obstructions? And as well as, and so that can be structural obstructions, or it can be functional, meaning the vessels are just vasoconstricted. So it makes it very hard to have a good stroke volume if that left ventricle, for instance, has poor contractility, and now it's trying to pump out against vessels that are very, very vasoconstricted. It makes it difficult. And that's, for instance, why a lot of our patients are on drugs like milrinone. They help the contraction better, and they afterload reduce, which means they make the vasculature after the left ventricle vasodilate. And that can be said for the right ventricle. You know, if patients have pulmonary hypertension, then maybe we need them on nitric oxide post-operative, and maybe we need them very, very sedated. So oxygen delivery is also dependent upon hemoglobin. So we need to know what is happening with their hemoglobin as they bleed out their chest drains. We need to understand what the optimal hemoglobin is for that particular patient. So for instance, you know, maybe this patient has a normal cardiac physiology or not a non-cyanotic heart defect. And so this patient comes back from the OR with a hemoglobin of 120, and over the course of the evening and the next day, maybe there's some bleeding and their hemoglobin drops to 100 or 80. You know, we may not transfuse them if they're doing well at all, or maybe we're going to transfuse them if it drops below 70 or at 70. And or maybe we're going to top them up to 120 if they're not doing well. Likewise, you know, for the cyanotic heart disease, so that an example might be hypoplastic left heart syndrome, where we might like to keep we often like to keep the hemoglobin around 140. If the patient's doing well and they have a hemoglobin of 120, again, we're not going to expose them to the risk of a blood transfusion. However, if they're 100 and they're not doing well, then we will try to get them to a hemoglobin of somewhere, just greater than 140 or 140 and greater. So we need to consider oxygen demand when assessing whether oxygen delivery is adequate. So we can have adequate delivery, but if we have a very high demand, then it may not be enough. So we monitor our patients, and our monitoring alerts us to the possibility of low cardiac output. It helps us to assess the possible causes and to evaluate any treatments that we've given the patient. So if we've started an epinephrine infusion, we have to examine our patient, examine the lactates, examine the mixed venuses to see if those interventions have actually made improvements and those values are returning to a better or normal level. So what do I have to be extra aware of low cardiac output? All patients are being assessed for low cardiac output, but not everybody will have low cardiac output. And the key is to identify those that are at high risk of low cardiac output, who are those with more complex lesions usually. We need to think about the operative report. What did they say about the ventricular function? Were there any residual lesions? Are those residual lesions intentional? And an example might be a tetralogy of Fallot with a very stiff right ventricle. We may have higher CVP pressures, and those CVP pressures may come down over time, but in some instances, if they're concerned about blood flow or cardiac output, we might actually, or the surgeon may actually leave a residual lesion of a PFO so that blood can shunt right to left. Yes, the patient will desaturate when they're shunting right to left, but at least they'll have cardiac output. And how are the AV valves? Do we have AV valve insufficiency? So do we have the mitral or tricuspid valve, which are leaky? So when these things are present, poor ventricular function, residual lesions, pulmonary reactivity, or AV valve insufficiency, then they may evolve or worsen over time. So where there is a higher concern, there needs to be more frequent examinations and lab assessments. There needs to be close communication and collaboration for these patients between nurses and physicians. And one of our main messages is that if you are concerned about a patient, always speak up. Even if it turns out to be nothing, at least you've you've raised awareness by the people who are going to be able to look at the big picture. And situational awareness is very important. And so actually this is a slide from Dr. Steve Schwartz, and it's just really a plank. And if I asked you to walk across that plank, probably if you just looked at the plank and you didn't think anything more about it other than it's a plank on the floor, you would probably have no problem walking across it. However, the context of the situation always matters. So if I told you that that plank was overlying that canyon, I'm sure probably most of you would tell me that you weren't going to walk across it. So we have to understand the specifics about that patient and the context of that patient, how they were yesterday, what the surgical repair was. You know, if for the tetralogy of flow, do they have a very stiff right ventricle, a thick wall, stiff right ventricle, or, you know, were they a tetralogy without so much diastolic dysfunction? So what do I need to know about blood pressure assessment? And, you know, when I was in nursing school, we were always taught to do blood pressure. But really, blood pressure, we still need to do it, but it's a late sign of changes. And we also need to pay attention to the systolic and the diastolic, as well as the mean. So in our unit, we monitor on the mean. And the mean arterial blood pressure is, you know, if we take, say, the systolic blood pressure here and the diastolic blood pressure here, the mean isn't 50% between the systolic and the diastolic. It really takes into consideration a lot the diastolic blood pressure. So the definition is really of a mean arterial pressure is the systolic plus 2 times the diastolic blood pressure divided by those 3 components. So 2 times the diastolic plus systolic divided by 3 will give us our mean. And of course, that's not the math that we need to do on a normal day-to-day basis, because our monitors will actually do that math for you. But to recognize that the diastolic blood pressure is something that we need to pay attention to. If the diastolic blood pressure is low, it means our vessels here are vasodilated. If our diastolic blood pressure is high, it means our vessels are vasoconstricted. So as we use dilators, vasodilators, or if patients are in warm vasodilated septic shock, our diastolic blood pressure is going to drop. And as a result, our mean arterial blood pressure will drop. If we only pay attention to our systolic blood pressure, well, our patient might be compensating. And our patients often compensate by tachycardia. So they may be able to maintain a systolic blood pressure to a point, and then they start to deteriorate and their mean arterial blood pressure drops. So if we're paying attention to our mean arterial blood pressure, we will notice earlier that and setting our alarm limits within tight limits around our mean arterial blood pressure, we will actually note when our patient deteriorates faster than if we just set our alarm limits around the systolic and only look at that. So blood pressure must be interpreted in the context of perfusion. A high blood pressure may be seen in the context of low cardiac output and a high systemic vascular resistance. So for instance, if I have a very high blood pressure, we actually may, so if we're very vasoconstricted, we actually may not have very good cardiac output because it can't get it out against the very vasoconstricted vessels. And a low blood pressure may be seen in the context of a good cardiac output and a low systemic vascular resistance. Also, a low blood pressure is a late sign of poor cardiac output. So you can have lost 25% of your circulating blood volume before your blood pressure drops. So we need to be paying attention to other aspects of blood pressure than just systolic blood pressure. This is another slide actually from Dr. Schwartz. And I like this slide because it looks at the relationship between cardiac output, blood pressure, and vascular resistance. So if you look at this first part here, we see the vascular resistance where your systemic vascular resistance is normal. And we see that we have a good blood pressure, and we see that we have a good cardiac output. And remember, cardiac output equals heart rate times stroke volume. And stroke volume is made up of preload, afterload, and contractility. So here, as our systemic vascular resistance rises and our vessels become vasoconstricted, well, up in this first part of the curve, we're able to maintain our systolic blood pressure, and our cardiac output seems to be good still, and our perfusion good, but it starts to drop off. And then you come to a point where it drops off steeply. So the higher our resistance, the lower our blood pressure, and the poorer our cardiac output. So what do I need to know about blood pressure monitoring? Well, we have continuous arterial blood pressure, usually in critical care units. Otherwise, we have intermittent blood pressure. And so when we're using continuous invasive blood pressure, so we often use the right radial artery line or or left arterial line, radial arterial line, or the femoral arterial lines. And so we need to set age-appropriate alarm limits. We shouldn't set our alarm limits too wide, because then there's going to be a lot of time where the patient is deteriorating before we actually know what's going on, or we're alerted to something that is actually going on. The other thing is that we need to pay attention to our monitors. We have something here, a monitor or a program called T3. And in T3, it gives us, it's actually a monitor above our bedside monitor, and it gives us trend data that's very easy to look at. So it's another computer sitting above our bedside computer, and in it you can see, the heart rate waveform, you can see the respiratory waveform, you can see the systolic, the mean, and the diastolic waveform, you can see any intracardiac pressure waveforms, and you see them all in relationship to each other. But what we really pay attention to is the pulse pressure, the difference between the systolic and diastolic blood pressure. And when patients have imminent arrest, we do sort of our monthly cardiac arrest reviews. And a physician and a nurse review the charts, and they look at all of the information around preceding and after that cardiac, during and after that cardiac arrest. And we look to see if this was a potentially preventable event. And so sometimes there's no change in your, if it's a sudden arrhythmia, for instance, then if you're looking at your arterial systole, diastole, and mean, you may have no pre-warnings because they're sudden events. But often in patients with poor cardiac output, there's a period of time where, maybe there are finer changes in your waveforms. And if we're able to see the waveforms and another monitor, instead of numbers, but all sort of trend data over time, then we might have noticed that the heart rate was starting to climb a little bit. And the pulse pressure, the difference between the systolic and the diastolic and mean, were coming together. And if we can identify early that we're seeing the pulse pressure narrow or widen, then we have an opportunity to potentially, in some instances, not all of course, to prevent a sudden cardiac arrest, or a cardiac arrest. Maybe it's not so sudden, but an impending cardiac arrest. So by notifying people, paying attention to your systolic, mean, and diastolic pressure, we may have an opportunity in some cases to change the outcome for that patient. So we also need to know that the information that we're communicating to people is actually accurate information. So when we have continuous pressure waveforms like an RA or an LA, so intracardiac lines, or a CV, then or central venous line, or the or the arterial pressure waveform from an art line, that when we change the level of the bed or the head of the bed, that we need to recalibrate our pressure line, re-zero our monitors, so that we are giving accurate pressure. So for instance, if we raise the level of the bed and we don't bother re-zeroing, recalibrating our lines, then the information that's on our monitors is not the truth. And so if it's not the truth, but the physician doesn't know it's not the truth, they may be actually acting upon it, which may be a false intervention. So we always need to make sure that we bring a baby down into the mom's arms, for instance, that we recalibrate our line, re-zero our lines, so the information on our monitors is accurate. So manual blood pressure monitoring then. We also need to make sure that we have the right sized cuff on our patients. If our cuff is too big, then we will have falsely low blood pressure. If our cuff is too small for our limb, then that will make our blood pressure for our manual measurements falsely high. So we have to make sure that the information that we're transmitting to others is actually accurate. So we need to assess all 4 parameters of blood pressure. So all ways of looking at blood pressure, systolic, diastolic, and mean, are related to each other and should first be looked at as a whole to assess the patient's whether the patient's organ perfusion pressure is adequate. So diastolic pressure tends to be related more to left ventricular coronary perfusion. So diastolic blood pressure minus left ventricular end diastolic pressure, which is basically the LA pressure, if we have an LA line. And so if we look at this infant's blood pressure and we see a systolic blood pressure of 76, well, we're happy with a systolic blood pressure of 76 for an infant. But we look at the diastolic blood pressure, which is 23, which is very low, which really is indicating to us that our vessels are vasodilated. So an example of that would be if somebody was on too much of an afterload reducer drug, such as milrinone, or nitroprusside, or phentolamine would be examples of infusions that cause your vessels to vasodilate. So of course we want the vessels to be vasodilated enough so that it makes it easy for the left ventricle to pump out to your systemic circulation and for the blood to get around and perfuse your organs and your distal limb. But we don't want it too low that you have a low mean arterial blood pressure. And so we don't want our pulse pressure too wide either. When we're thinking about, well, what is normal for blood pressure, a nice tool to use is a PALS card. So a pediatric advanced life support card. They can be ordered through Heart and Stroke, or other similar organizations. And they have actually a chart with a normal heart rate, a normal respiratory rate, a normal mean arterial blood pressure. So what we did was laminate them in our unit and actually attach them to the cardiac arrest cart so that people can look at them there. But also they, many people, because they take PALS, have them as sort of pocket cards as well. So that's diastolic pressure, the lower one. It's looking at, if you're very vasoconstricted, that number would be high, and your pulse pressure, the difference between your systolic and diastolic, would be much narrower. So, for instance, a patient who is in tamponade, your vessels, because you have poor cardiac output, whilst your systolic would also drop, your diastolic would come up, and your pulse pressure, the difference between your systolic and diastolic, would narrow. So again, just going back to that concept of what's a normal blood pressure. So when we're looking at systolic blood pressure, I like the PALS way of kind of thinking about it. If you're a a newborn, that's term, your systolic blood pressure should be in the 60s. If you're a 1 month old, then you're a 1 month to 1 year old, then you're, sorry. If you're a 1 month old to a 1 year old, then your blood pressure systolic will be in the 70s. If you're 1 year to 10 years, then it should be 80 plus 2 times age in years. So if I'm a 4-year-old, that translates to a 4-year-old, so 4 times 2 is 8, plus 80 is 88 systolic, would be a normal. 70 plus 2 times age in years would be the minimal that it should be. So 5% of children, or the 5th percentile, will have a blood pressure of 70 plus 2 times age in years. But 95%, if it's lower than that, that is not normal. So systolic pressure tends to be more related to right ventricular coronary perfusion, so systolic blood pressure minus the right ventricular systolic blood pressure. So remember, the right ventricle usually has a lower systolic blood pressure because it's usually pumping to the lungs. But when you're a newborn, it does have a high pressure. And that gradually drops over time. So in this instance, this patient, who's a toddler, has a systolic blood pressure of 56/35. So that is an inappropriately low blood pressure, systolic blood pressure for a toddler. As we said, our mean arterial pressure is 2 times the diastolic, so it really takes into account what your vessels are doing. Are they vasodilated? Are they vasoconstricted? Plus systolic, plus divided by 3 of those. And it tends to be a good overall target for assessing and managing blood pressure. So in this instance, this baby has a systolic blood pressure of 70 over a diastolic of about 35 over the mean. Over the the mean is 2 times 35 plus 70 divided by the 3 of those will give you a mean of 46. And the pulse pressure is the systolic blood pressure minus the diastolic blood pressure. And it's related to the way the pulses feel to your fingers. So a narrow pulse pressure indicates a low stroke volume. An example of a narrow pulse pressure is a tamponade. So when your heart, is being compressed by a tension pneumothorax, so air around your heart, or blood clots just sitting on your heart, or pericardial effusions, compressing your heart. So again, that may be air or blood or pus or fluid. And so that then causes your heart to not be able to fill properly and not be able to eject properly, so your systolic blood pressure drops. And yet, because your systolic or your perfusion drops, your brain tells your adrenal medulla and to send out endogenous epinephrine and norepinephrine. And those cause your vessels to vasoconstrict and your heart to pump harder, but unfortunately your heart is compressed. And so your diastolic blood pressure comes up because your vessels are vasoconstricted, trying to get the blood to your brain and your heart, the most vital organs, at the expense of many of your other organs. And the pulse pressure, the difference between the systolic and diastolic in this example, is only 10. A wide blood pressure can indicate a lesion where blood can go somewhere beside the systemic circulation. So in this patient, they have a good systolic blood pressure, but a poor diastolic blood pressure. An example of that is arterial pulmonary collaterals, aortic insufficiency, or a Blalock-Tussig shunt. So how do we know if the blood pressure is the right for the patient? So if the blood pressure is in the expected range, then assess the patient to be sure perfusion, cardiac output, and oxygen delivery are good. If they are, then your assessment is that everything is fine. So if your blood pressure is an okay range, then that's good. If your end organs are receiving the blood that they want. So we're assessing the perfusion. What is our capillary refill? And remember, our capillary refill is, whether you're doing it centrally or peripherally or both, you're compressing for 5 full seconds and letting it go and watching the capillary refill time. Capillary refill time should be 1 to 2 seconds. Any delay in the capillary refill is a sign that your perfusion is changing. We also need to look at our level of consciousness. Do we have enough adequate cardiac output to meet the needs of the brain? Or are we lethargic or have no level of consciousness? And then we also need to think about the pulses and the warmth. You can tell a lot from holding somebody's hand and feeling the warmth in their extremities, feeling the pulses of their arterial and femoral and pedal pulses. If the blood pressure is higher than expected, assess the patient to determine if it's due to high systemic vascular resistance. Are they all mottled and cool peripherally? Is it due to a high cardiac output or both? Assessment should include perfusion, pulses, color, capillary refill, and lab assessment. So what is their arterial blood gas doing? What is their mixed venous oxygen saturation doing, which is taken from a free-flowing central line? And what is their lactate doing? So we want to see a lactate of coming down to 2 or less. Is the blood pressure so high that you need to treat it? This is dependent upon your patient's usual blood pressure, the lesion, and what the cause is. If the cause of increased cardiac output and high systemic vascular resistance is pain, then we're not going to treat with nitroprusside or milrinone or phentolamine. We're going to treat with pain relief. So we need to make sure that our treatment matches our problem and that we've identified our problem correctly. Your assessment informs how you will address the concern itself. So how do we know if the blood pressure is right for the patient? So you need to understand the story of the patient to help determine the possible causes. So we always think of it in the context of the patient, in the context of this patient. So not the previous, tetralogy of Fallot, for instance. You're looking at tetralogy of Fallot in general and understanding the defect, but understanding this patient's defect. Do they have any residual shunts? Do they have a very a very thick right ventricle and therefore have diastolic dysfunction, which means the inability of the ventricle to relax and fill. So maybe that particular patient needs a higher CVP to get the blood to move forward. So understanding the story of the patient, we need to help determine the possible causes. So for a coarctation of the aorta, we don't want that patient to be have systemic hypertension post-op because we might have, a breaking of or bleeding through the sutures if we have a really high pulmonary hypertension. So often we repair coarctation of the aorta by cutting out the narrowing and suturing the aorta together. So if we allow them to be very hypertensive, then we may have increased bleeding. So if the blood pressure is high, there's a risk of stroke and bleeding. And newborns are also at risk of intracerebral hemorrhage from hypertension. If the blood pressure is lower than expected, well, we need to assess the preload. So what is the CVP? And really, we're going to talk about this at length when we get to hemodynamics in the second semester. But you will begin to hear things over the next couple of months as well as people present, both you within your presentations about congenital heart defects and also about the case presentations. So assess preload. How full is the heart? Are they underfilled because they're in a cardiac tamponade? And what are we going to do to relieve that pressure around the heart? Assess the afterload. Are they too vasoconstricted? Are they too vasodilated? We're going to look at the drugs they're on. We're going to look at their usual systolic and diastolic blood pressure, the contractility, heart rate, and we're going to treat the cause. If they're bleeding, we're going to treat with volume and blood products. We're not going to treat with epinephrine. So we have to make sure that the treatment matches the problem. We have to make sure that we've really identified the problem in the first place. And we use the interprofessional team to make sure that we really, understand the problem. We are going to ask for ideas if we're not sure of the problem. So what are the signs of poor tissue perfusion? So now that you know your blood pressure, assess whether there are signs of low cardiac output associated with it. So what are their extremities like? Are they cool and mottled? Do we have delayed capillary refill? Do we have metabolic acidosis when we do our blood gas? Do we have a low mixed venous oxygen saturation when we take it from our free-flowing central line, whether that's the neck line or whether it's the femoral line? And in terms of lactates, we're going to look at the absolute number. So we want it less than 2, but we're going to look at the rate and rise of fall. So for instance, a patient might come back if they've had a very long and difficult operative course. Maybe they come back with a high lactate like 12 or 15, but when you do serial lactates every hour, you're noticing that every hour that number is coming down. We want to pay attention to the urinary output. If we have inadequate cardiac output, then we're going to have inadequate perfusion of the gut and the kidneys. And if we have inadequate perfusion of the guts, we stop tolerating our feeds. If we have inadequate perfusion of the kidneys, we no longer have that 1 to 2 mils per kilo per hour of urinary output. But of course, we always have to think about the context of the patient. So for instance, if that patient had a urinary output of 2 mils per kilo per hour, 1 to 2 mils per kilo per hour, fresh post-op, and then 6 hours later, it's dwindling off to half a mil per kilo per hour. Well, maybe that first hour will be our red flag, but 2 hours of low cardiac output is when you need to communicate to your team because something is wrong. Maybe they're bleeding, or there's some other reason that we're underperfusing the kidneys, or maybe we have kidney failure. So each of these assessments needs to be in the context of the entire picture, of the context of the patient, their defect, where they've come from. So for instance, if a patient was not voiding at all post-op, and then we give them some Lasix the next day and they start to void half a mil per kilo per hour, then we're doing really well. We want to get to 1 to 2 mils per kilo per hour. That's our goal. But if we've been anuric, and let's say they came back anuric, but in a few hours they start to void 1 to 2 mils per kilo per hour, or start to head towards in that direction, then we're happier than if we started with a good urinary output and we're heading out with a lower urinary output than what we expect. So at any rate, any signs of low urinary output, we're going to let the team know. So trends in lab tests are important. Are they heading in the right direction, or are things getting worse? So a patient with a lactate of less than 2 post-op, and when we do a serial in 1 hour, it's now 3 or 2.5, and then 3 and 4 and so on. That patient, in relation to the patient that came back with a lactate of 10, but it's heading down to 9 and 8 and so on, we need to decide what is happening with that patient who started out with a good lactate and is heading for the worst. So we want to see the direction in the right direction. So low cardiac output states and inadequate tissue perfusion alter the lab test. So for your arterial blood gas, we'll be in a state of metabolic acidosis with hypoxemia and lactic acidosis. Metabolic alkalosis could be from diuretics. So if you think about back to that arterial blood gas analysis class that we did earlier on, that it's important to look at all of the things that might be leading to that. So higher rising lactates is a marker of poor tissue perfusion. If we have poor cardiac output, then we have poor tissue perfusion, and these poor cells in the distally, they undergo anaerobic metabolism instead of aerobic metabolism, of which the byproduct is lactic acidosis. So serial measurements are important. It can signal impending circulatory failure. Just like when we told you, when you're looking at trend analysis of your arterial line, we don't want to see the difference between the systolic and the diastolic coming in on the mean arterial blood pressure. That's an ominous sign, pre-arrest sign. And we need to be identifying that early and communicating it early so that there can be some early intervention and prevention of cardiac arrest. Rising blood urea, nitrogen, and creatinine can be caused by renal dysfunction secondary to low cardiac output. So we want to pay attention to our cardiac output and our urinary output. So what do I need to know about hemoglobin in patients with inadequate oxygen delivery? So blood transfusion therapy should be based on the need for oxygen carrying capacity and not the need based on a hemoglobin number. So that's where I said that, maybe a patient has a less than optimal hemoglobin. However, they've got good lactates, they're warm and well perfused, they're good neurological status, and they're voiding an adequate amount. That we probably won't go ahead and transfuse them just to get a good number for hemoglobin. Children with signs of low oxygen delivery may benefit from an increased hemoglobin up to about 140 milligram per deciliter. The exception to this is children who are very polycythemic due to prolonged cyanosis. So this is just giving you an example about understanding the context of that patient and understanding the context of that patient over time. So an older patient post-repair of tetralogy of Fallot with preoperative polycythemia, so for example, maybe this patient has a hemoglobin of 220, who now has a post-operative hemoglobin of 120 and is not doing as well as expected, well then maybe we'll transfuse them to a higher hemoglobin because they're so used to having a hemoglobin of 220. Patients who are still cyanotic can increase oxygen delivery with a transfusion by increasing the mixed venous oxygen saturation and thus arterial saturation because of right to left shunting. So what do I need to understand about oxygen consumption? Oxygen delivery and oxygen consumption must balance. We can't have a poor oxygen delivery or a too high oxygen consumption. They need to be balanced in order to have a good lactate and have a good mixed venous oxygen delivery. So we have to try and determine, is this a problem of oxygen delivery, so a poor heart that can't pump out well, maybe because the patient is too vasoconstricted? Or is it a problem of tissue extraction, or both, meaning the patient has a high oxygen consumption and high oxygen extraction? Patients with limited oxygen delivery may need to have their oxygen consumption modified. So what that means is sometimes when patients are really ill, have had complex surgery or septicemia, and they are really doing poorly, then sometimes we have to moderate their oxygen consumption by maybe sedating them really well, giving good pain relief, and even sometimes we have to muscle relax them and so that they're not over consuming. And sometimes we have to cool them, so again, they're not over consuming. So these are protective strategies. What are the causes of increased oxygen consumption in the patient? What are the things that we can do to decrease oxygen consumption in this patient? So in particular, what is going on with this particular patient? So when we think of factors that increase oxygen consumption, there are many. Is this patient febrile? So for every degree of rise in in temperature, increases your oxygen extraction. And we'll see how much when we come to the hemodynamic class, after the holidays in January. So fever, pain, agitation, care activities, suctioning, bathing, turning, procedures. So it's not like we don't have to do those things. We do, but we have to look at how our care actually increases their oxygen delivery, so increases their oxygen consumption. And maybe we have to moderate what we're doing. So maybe they can only tolerate our clustering our care, allowing for good periods of rest. And maybe we can't do everything. Maybe for this patient, we like to give our patients baths every single day and change their bed sheet so that we potentially limit the central line bloodstream associated infections or CLABSIs. But sometimes maybe we can't do a full bed bath if the patient is really, really ill. Or maybe we just have to moderate our activities at some points. So do the limbs, at in another few hours, for instance, do the face and the pericare now. So we also have to recognize that patients have seizures, and not all of them are clinical seizures that we can see, and that we have to look at other markers that might be demonstrating to us that our patients have potentially seizures, like delays in their pupillary constriction, for instance, changes in their vital signs. Shivering markedly increases their oxygen consumption. Drugs such as epinephrine. And epinephrine at a low dose as an infusion, 0.01 mic per kilo per minute, 0.02 mic per kilo per minute, 0.05 mics per kilo per minute, for instance, may not increase their oxygen consumption. But the higher that we go, 0.06, 0.07, 0.1 mics, and so on, really increase the oxygen consumption. And so if you are in a state of poor oxygen delivery and have a high oxygen consumption, you're not going to do very well clinically. So how can we decrease your oxygen consumption? Well, we treat the cause. If your increased oxygen consumption is related to fever, then we give you Tylenol. If it's related to pain, we give you analgesia. If it's related to agitation, we administer sedatives. If it's care activities, well, maybe we really need to cluster our care, assess for tolerance, and moderate our activities accordingly. Seizures, we want them to stop seizing. And remember, sometimes they're subclinical. There are no overt signs. So doing EEGs to assess, or continuous EEGs to assess those at risk. Shivering, prevent shivering, and then consider alternative drugs that maybe have less oxygen extraction, such as milrinone over epinephrine. So we need to use tools to understand that supply and demand situation. So we can use invasive monitoring, so taking mixed venous oxygen saturations from free-flowing central lines. Or we can use non-invasive, so near-infrared spectroscopy, or NIRS, which is regional oximetry. It's looking at, if we put it over the cerebral, so on the forehead, for instance, and not midline, needs to go on one hemisphere or the other, and it's looking at venous and arterial, sort of blood flow and oxygenation, and looking at the trend in NIRS, information. So whenever you turn that patient, did the NIRS, as we see here, the left, they only had one sensor on, but the sensor showed a regional oxygen saturation of 68. But when you turn the baby on their left-hand side and you do a full turn, does that NIRS drop? And how long does it take to respond back up? So of course, there are some limitations to NIRS monitoring, and so we use it more as a trend monitor. We also take mixed venous oxygen saturations, which give us an intermittent reading. And so mixed venous oxygen saturation left in the blood after it has been distributed to the tissues. So it's a marker of balance of oxygen supply and demand. And so mixed venous oxygen saturation decreases with increased oxygen extraction or a decrease in oxygen delivery. So either of those components affects the mixed venous that you get back. And if you think about normal physiology, so usually if you take of a normal anatomy of a well person, for instance, no holes in their heart, and you have a sat probe or you take it from their arterial line, it will have an oxygen saturation of about 94 to 99% or 100%. And then you take it out of the art line, and you also take it out roughly at the same time, or one after the other, because it's not possible to do it at the same time, is we take some blood out of their central venous line. And as your blood, your left ventricle delivers the blood to your body, as it courses around your arteries and arterioles and comes back through your venules and veins, back up to the right side of your heart, well, it's extracting oxygen all the way on that path. So under normal conditions, it extracts about 20 to 30%. So to keep the math easy, if your oxygen saturation on your arterial blood gas or your hand is 100 and your body extracted 25%, because it's an easy number to remember, then when you extracted it from the neck, your mixed venous oxygen saturation would be 75%. The true mixed venous oxygen saturation comes from the pulmonary artery, but we don't have PA lines in most patients. In fact, it's not that frequent that we see it unless we're really worried about pulmonary hypertension. And so we use the next best thing, which is our central line. We prefer to take it from the, closest to the heart. So the SVC, for instance, then the femoral. But essentially, we don't always have that choice, and we'll take it from where we can get it. So if you compare that for somebody with an acyanotic, so normal heart physiology, or, where we have a mixed venous oxygen saturation 70%. So send it out 100%, your body takes away, extracts about 20 to 30%, giving us, when we suck it out of the neck, 70 to 80%. And a cyanotic physiology, well, they actually start off with a much lower saturation. So let's say a single ventricle might have a saturation between 70 to 80 or 75 to 85. So let's say, for easy math, they have a mixed venous of 75% on their art line or on their finger from their saturation probe. And the blood courses throughout their body, and their body's extracting it all the time. And when it comes back to the SVC, we suck it out, send it off to the lab for testing of mixed venous oxygen saturation. It comes back 50. So 75 minus 50 extracts 25%. Really the mixed venous oxygen saturation in, say, a hypoplastic left heart syndrome, for instance, would be between 45 to 55. That's what we'd expect, not 70 to 80%. And so a mixed venous of less than 40 or even less than 45, those are sort of critical. Less than 40 is very critical. So it indicates a real risk to organ injury where we have an imbalance of oxygen supply and demand. And so we need to take sequential determinations of this, which are useful. So it's the trend analysis that are useful. Yes, the number itself, but also the direction. Is the mixed venous saturation improving, or is it getting worse? We need to intervene with our therapy and then reevaluate our response to therapy based upon the changes in the lactates and the mixed venous oxygen saturation. So here's an example of that AVO2 difference, which we said in you and me is about 20 to 30, the difference between your arterial and your venous. That's AVO2 difference, the difference between the two. So say we have an arterial oxygen saturation minus a mixed venous, or an arterial saturation minus a mixed venous. In our first instance over here, we have an arterial oxygen saturation of 100%, which is normal. And once it goes through the body and your body extracts 25% of it, or 20 to 30% of it, in this example, we have a mixed venous of 75%. So the AVO2 difference is 25%, 100% minus 75, 100% in your ART saturation or your sat probe on your finger, minus 75%, which is what is left when your body has consumed it. Then we're happy with that. But what about this example over here? So in this example, this patient had a saturation of 100%, but their mixed venous was 56%. So that should actually be 100, not, so it should be 100 minus 56, right? And so we'll see, you know, a much wider AVO2 difference. So that could be because of a low delivery, poor cardiac output, or it could be because we're consuming at a mile a minute, right? And so we have a high demand. So we have to figure out what's the problem. Is it a problem of low delivery or high demand? Or in many cases, in very sick patients, it's both. So a wide AVO2 difference, this is the same thing as seeing somebody with poor perfusion. It should prompt you to assess further. When you see a wide AVO2 difference, just like a low blood pressure, think of all of the reasons why. Do an echo and now look for other reasons. This will depend on what you already know and what you don't know about your patient. So coming back to these two, our patient A, our VSD, remember that's a fairly simple, straightforward repair, but what do I need to consider or think about in relation to the blood pressure, cardiac output, oxygen delivery, and oxygen consumption for this patient? What are all the threats to this patient? So fever, infection, seizures, bleeding, strokes, arrhythmias, renal failure, renal dysfunction, necrotizing enterocolitis, or poor, gut malabsorption or absorption. And so I might expect less of a problem from this patient, but again, I should never let my guard down. And this is our truncus patient. Well, we know he's at high risk, it's evident. His chest is open, he's got sternal suspension so that his chest wall is lifted up off the heart so that the heart can have room to move in. But what do I need to consider when I'm thinking about his blood pressure? Might I have pulmonary hypertension, in which case maybe our, when we have pulmonary hypertension, our right ventricle is trying to pump it against our pulmonary vasculature, but our pulmonary vasculature is very tight. And so our right ventricle is having difficult and it becomes sort of round, and our septum is actually being pushed over into our left ventricle, taking up space in our left ventricle, impairing preload to our left ventricle. So really the take-home message of this session is assess your patient frequently. Recognize even the most subtle signs of clinical change. And when the parent says something about what they see that they don't think is normal, take it back to the physician and tell them about it. And they can, have further investigation. Notice trends in lab results. So take a test, look at it, compare it to previous. Have you maximized your oxygen delivery? Are there other things you can do? Hemoglobin, ventilation, oxygenation, preload, afterload, and contractility. Have you minimized your oxygen consumption? Sedation, pain, managing fever, limiting overhandling of your patient, allowing for patients to rest. If your patient changes, reassess and reevaluate. If you administer something, you would intervene somehow, reassess and reevaluate. Airway, breathing, circulation, disability. Speak up when you're concerned and get expert interprofessional consultation. So remember, preventing cardiac arrest is a team effort. So communicate, communicate, communicate. Thank you.